G'day everyone, and welcome to another live stream. We've all made it through another week. I don't know about you guys, but I had a late finish today. One of those times where my last patient was supposed to be booked at 4:30 and I didn't get out till 6:15, 6:20 I think it was. Another day in paradise. So glad some of you could join me here tonight. We'll try and smash through some more practice KFP questions. Obviously, this is a study group aimed at helping you pass the KFP and hopefully helping me as well. So we're all in this together. We'll run through the practice questions. I'm going to change things up a little bit this week after some feedback from last week. Rather than have kind of this disjointed answer a couple of questions, then go through answers, we'll kind of tackle each question individually, then go through the answers and highlight some of the key points in there for learning. Now, all of you have been watching your emails with trepidation and bated breath, and I can say that there has been confirmation that the exam is going to be changing. So we'll talk a little bit about that and what the implications are there, and ways we can also adapt our learning style and technique and approach to the exam based on this change. Starting off though, let's bring up today's sponsor, sponsored by me. So my name's Kane Treble. I'm a GP registrar up in Mildura, Victoria. I'm doing this in my own time, again, to try and help people with their study process. If this is something you find helpful, please consider subscribing so that we can make more. Moving on to the important stuff. So again, the format has been changed, confirmed that the 2023.2 KFP exam will now be paper-based. So for anyone that's been practicing online, best to start practicing with pen and paper now. This does have implications for your exam technique, and we'll talk through today some of the things you might be able to try out. But one of the best things I can try and encourage you to do right now would be to actually try and print out on physical paper any practice questions or practice exams that you're doing and practice writing out the actual answers. Having sat and unfortunately failed the start of your KFP, where it was last minute change to written, one of the biggest frustrations I had was having to suddenly go from typing answers as we do in the clinic all day, every day, to suddenly have to handwrite things out. And certainly muscle cramping in the hand was a big problem after 4 hours of non-stop writing. I thought we'd also kind of start back from first principles for those who might be late in the game in terms of preparing for the KFP, and what exactly is the point of the exam. As the name implies, it's the key feature problem. We want to be able to extract the key information from a STEM. So the best way to kind of approach that is to identify the case demographics. What is this patient? What is this setting as well? Because the situation, the location in which these cases are based will dramatically change, or should dramatically change, the way you answer it. It's the difference between being told you are working in a rural emergency department versus being in a metropolitan GP clinic. Again, also looking at the patient demographics, so age, gender, any socioeconomic status, highlight pertinent symptoms and signs. And this can often lead to a lot of kind of notes scrawled absolutely all over the page, and that's perfectly normal, perfectly fine. Note any relevant medical history, and I try and do this a little bit different, and I'll show you guys in a minute when we get to a question my approach to this, so that I'm not just in a sea of underlines, as well as paying attention to contextual clues. Pardon me. One thing that the college seems to be giving lots of good feedback about is they're not trying to trip us up. If they're giving us information, it's because that information is important. If the information's not there, you can presume that it's either not there for a reason or not important to the case. Likewise, make sure that you're actually answering the question that is asked. And I know personally this caught me up once or twice. And one easy approach to that is to preload the answer slots. So in the exam, you're usually given a blank space in which to write your responses and look at the question that's asked. One of the first things I do, because this has caught me out lots of times, is to actually write down what it was that, what response was actually made. Oh, just checking messages there. Cool. What response actually requested, and so if they ask for 3 specific responses, I will write 1, 2, 3. That way I know when I actually get to answering it that I'm going to be trying to fill that out, and probably just as just as importantly, I'm not going to be trying to provide 4 or 5 answers which will get me into overcoding and lose me marks. Likewise, identify the action that's required, because it's a difference between provide an answer that will most likely lead to the definitive diagnosis versus what investigation is likely to lead to the diagnosis versus what differential diagnoses would you be asking for. And like with that, the qualifier. So sometimes they'll specify the most important response or the most important differential to consider, in which case you're really only going to be considering those big red flag items. Consider potential variations as well, and this is as much for when you're practicing questions to think about how different clinical situations might actually change your response. That can also be a handy trick to work out ways to diversify your answers if you're struggling to actually find multiple ways to answer that question. And of course, apply your critical thinking. See if you can actually break it down to what are they actually asking here? What are they actually wanting me to put forward? When you're actually writing out your answers, probably the most important thing for the KFP is to be very, very specific and concise. And so one example I've given previously was a patient with mastitis. You would never write mastitis as your answer. You should be writing acute mastitis of the left breast, for example, and you could even go so far for some infections in particular to be specifying acute bacterial mastitis of the left breast. So not adding any additional information that's not required, but being super duper specific about what exactly you're trying to get at. Sorry guys, a few coughs tonight. Not COVID, I promise. So tying into that, why do they want you to be like that? They're wanting you to demonstrate that consultant level knowledge. And probably the handiest way to keep this in your mind is pretend you're writing a radiology slip that's going to be read and interpreted by a first day radiologist that's never done the work before. You need to really spell out the specifics of what you're after, what side, what site, the acuity of it as well, and try and build that into your routine of answering. Now, something that I know I certainly struggle with is avoiding overcoding and excessive complexity. Sometimes knowledge can be your worst enemy, and you're wanting to demonstrate your knowledge and handle over a particular topic. That's not for the KFP. The KFP, you really have to try and simplify things down as much as possible. And so I'll go into it in a moment as well, but there's a thing of no ifs and or buts. If you're using any of those kinds of things, you're going to find yourself in trouble. Now, I'm going to skip ahead a little bit, sorry, because I've realised I've actually made slides on each of these things. So yeah, specifying acute versus chronic, left versus right, bacterial versus viral. No ifs and or buts. If you're finding you're using any of those words there, you probably need to be thinking, am I overcoding? If in doubt, cut it down and simplify, and try to give specific samples over classes of things. So instead of saying infection, give an example. So let's pretend we have a patient with abdominal pain, and one of the answers we want to give is possible infectious cause of that abdominal pain. I wouldn't be saying infection. I would be giving the example of, say, appendicitis or acute viral gastroenteritis. So trying to really niche down as specific as possible, because remember, at the end of the day, it's a clinician that's going to be marking this. If they can see that you're kind of going down that infectious pathway, they're going to know, yep, okay, you're considering those kind of infectious processes as a potential cause. With that, also try and diversify your answers. So if you look through any of the previous exam papers that have been released, which unfortunately I can't link to any because that would be against the exam policy, but when you get access to some of these things, you'll see that some of the responses are grouped, which means that if you answer multiple of those answers, they'll only be marking one of those. And likewise, each group will have a specific maximum number of marks available to it. So rather than risking giving multiple versions of the same answer or same class, for example, try and think what are the best ways to actually break the answers out across multiple domains as much as possible. So avoid multiple versions of pharmacological management, avoid multiple similar referrals, such as to a physiotherapist and a kinetic physiologist, Again, it's that fact that there's a clinician marking these, so they'll be ticking that box to say you're using those movement-based treatment pathways. And a handy way to kind of get this into your head is to picture the patient having to walk into different buildings to get things done. If they're going into the same building twice, you probably need to consider changing that answer to spread the response out. Avoid abbreviations and acronyms. So we've had confirmation that the common sense rule applies, but for best possibility of actually getting the answer right, don't use any abbreviations. So if, for example, they're talking about a cardiac case and an irregular heartbeat and you forget and write AF, the clinician marking that's going to see that, know exactly what you're talking about and say, yeah, cool, I'm okay with that, most likely. But to minimise any chance of any misinterpretation, the official advice is still don't use abbreviations, don't use acronyms, even ones that you think everyone knows. Try and presume that nobody knows that other one, and a handy thing, if you do have a few minutes free at the end of the exam when you're finished, try and run through quickly and catch yourself, have I used any abbreviations anywhere? And of course, try not to repeat any information from the STEM. So if it's not in the STEM, don't presume anything, so try not to make up any new information. It's particularly important on counselling or therapeutic options. So if they haven't specified the patient's a smoker, you shouldn't be putting down any response about smoking cessation, for example. Now, there have been a couple of practice exams that have kind of caught out things like that I've seen. And I think the responses I've had was, well, yes, that's not a very good question, and in reality we probably wouldn't be accepting that. If it is in the STEM, though, it's either useful information or it's already been covered. So don't put it in management, but consider using that in some way, shape or form in other aspects of answering the question. And so if it does mention they're a smoker, take note of smoking cessation as a potential option for treatment then. Does that make sense? Excellent. Moving on. Let's get to some practice questions then. And again, similar to last week, we'll put 2 minutes on the clock, knowing that you'll probably have a bit more than that in the actual exam. But this is, again, just to give us a bit of practice and keep us on our toes. So Gary's 47 years, attends the rural general practice, complaining of 3 days of left-sided abdominal pain. Began as a sudden sharp pain in the back, but seems to have moved around to the flank. He experiences sharp episodic pain that has lasted for hours before suddenly settling but later returning. He's uncertain what the cause is, has a past medical history of hypertension managed with perindopril 2.5 milligrams, and has no known allergies. There's a BMI of 26, he does not smoke, drinks 2 cans of mid-strength beer each night. What further history would confirm your suspected diagnosis? Write 4 history questions in note form. All right. So I thought I'd give a little example here of my approach to actually structuring my responses in the actual exam. So you can highlight on the page and underline certain details. I try and underline the actual clinical notes from the case and then circle the things that I'm potentially going to be using for the management side of things. In particular, if I note something that they've made a particular point of, such as that he drinks 2 cans of mid-strength beer each night, I put a little star or something extra to remind me to go back to that, because there's a chance that might become a particularly important piece of information. Happy with that? Let's see what some of the suggested answers are. So this is we should go back quickly. What we're asking for here is further history, so we want to make sure that we're not going to be repeating any of the same things that we've already got of suspected diagnosis. This is one thing I actually like about the KFP exam, is that they presume that you've already kind of clicked here with this kind of case what the actual situation is. They're not going to be asking you about necessarily what the diagnosis is, so much as the questions that kind of lead to that kind of diagnosis. And so it's kind of taking that step forward, but then pulling you back and saying, well, how did you get there? Right, 4. So we want to specify that we are only answering 4 things. History questions in note form. You ready for the answers? So, is there any hematuria? So this is a case of renal colic. Hematuria is a not uncommon finding with renal colic there, and certainly leads you down that pathway. Are there any other lower urinary tract symptoms, such as frequency, dysuria, or urgency, all very common with renal colic? Does this exacerbate, or does anything exacerbate or alleviate the pain? So classically, renal colic is one of those things that no matter how you try and position yourself, it's going to be not a fun time for you. And so again, these are also good questions that, if those things aren't there, would also help try and clarify, well, what are the differential diagnoses and does it lead to any of those? But they are quite specific to renal colic being the answer. And again, confirming the suspected diagnosis. Tied into that as well, you could have things like, are there any changes with eating and drinking, which helps exclude potentially other GI causes? Is there a diet high in salt, which is associated with renal colic? Any fevers, sweats, or chills can be used to help clarify, could there potentially be a septic picture or infected stone, which certainly can happen. I've had one a couple of weeks back, which unfortunately she was pretty sick. Fortunately, she's now much better. Has there recently been any dehydration or inadequate oral hydration, which again, dehydration is something that can promote stone formation. Change in bowel habits, again, querying other GI causes. Any family history of similar presentations or renal colic, again, you're kind of specifying down. And we do know there can be a genetic component to families that are more likely to produce stones. And of course, is there any personal medical history of renal colic? That is one question that they have not significantly mentioned no other past medical history. However, they have specified he has a past medical history of hypertension. And so that would be one that I'd probably leave as a last response, given, again, we're trying to avoid potentially adding things to the history when they've kind of already suggested that there isn't anything else there. Everyone happy with that? Excellent. Throw comments down below and I'll try and get to them as well as time goes on. Ready for another question? We'll put 2 minutes on the clock. Here we go. You examine Gary after completing the history. What elements of examination that can be performed in the clinic would be important to perform? List 2 specific examinations. All right, how do we all feel about that? Let's get to the answers. Again, highlighting that this is examination, in particular things that we could do in the clinic, listing 2 specific examples, so pre-filling that, putting down 1, 2, making sure I'm filling all the questions that are being asked. Answers. So, urinalysis to assess for hemoglobin. It's a bit of a controversy, whereas would this be examination or investigation? I've seen this in practice questions and been an accepted answer. So I would put that down. Of course, your other clinical signs for renal colic would be palpate for costovertebral angle and left flank tenderness, given we've specified this is a left abdominal pain. Likewise, you also investigate for vital signs, for signs of fever, tachycardia or hypotension as well. You guys ready for the next one? 2 minutes on the clock. And time starts now. You send Gary for further investigations. He returns 3 days later after you've been off yesterday on a non-rostered day. You see his results had returned with significantly abnormal results, but had been marked as normal, no action by another doctor checking your results. Gary's quite upset and worried that his results may have been missed without his representation. What steps could be taken to prevent this from recurring? Write 6 specific management steps. Sorry, lost the clock. All right. So again, just highlighting some of the salient features, things that I don't want to be missing, pre-filling those answer prompts. Let's go through. So this kind of question and this kind of turnaround as well, where it's kind of leading you down one path, then switching it up to cover another domain, is not uncommon in KFP questions. And so in particular, this is looking at clinic processes, which is one of the kind of domains of the college, and so it's something that they want you to be thinking about as well. Thankfully, they've actually got some guidelines out which tie into practice accreditation as well, and these are some things that you need to be familiar with, and some of the things there would be to actually address the issue directly, and that would be through discussing with the fellow practitioner, the other GP that checked these results. Discusses the situation with the practice manager as well to highlight that there is a potential systems issue there that needs to be addressed at a higher level. And again, another acceptable response there would be to raise it at a practice meeting or clinical meeting to discuss with the peers of the clinic. But then step through, well, what is the process itself? And so the first thing there is to make sure that all results are reviewed appropriately, to ensure that all results are appropriately annotated with the doctor's name for tracing back who's been marking things down. Ensure all results are incorporated into the patient record. Ensure the practice has a recall system to notify patients of significant results. Ensure patients are aware of the clinic's process for following up on the results, and this is something that should come up in day-to-day conversation with the patients as well, of if something happens, what are we going to do about it, how am I going to notify them. Likewise then, ensure the practice initiates and manages patient reminders. So there should be something there to actually let the clinic contact patients in a way to let them know the results are either there or need actioning. And of course, a process to identify and manage abnormal and life-threatening results identified outside of normal opening hours. So this isn't necessarily that if a result comes in at 2 a.m, someone's able to action it. In reality, if a result is that abnormal, then the lab itself should be contacting the doctors involved. More likely it's going to be something that's less severe, but might be faxed through to the clinic at 2 a.m. Is there a process in the clinic for someone when they first get in to be checking those things and highlighting the results to an appropriate physician or doctor to be actioning further? So again, this is something that is probably worth remembering. This is something that does come up as actual questions. And let's move on to the next question. So we've got a whole new case coming up, a fresh start if you weren't happy with the last case. And we'll bring 2 minutes on the clock. Shirley's aged 68 years, attends your GP clinic with a 3-month history of generalised itch. It began suddenly and she's unsure of the cause. She has no significant medical history, takes no medications and has no known allergies. She's no recent travel, doesn't smoke, drink alcohol or use illicit drugs. Shirley, you sound a bit boring. To examination, she appears generally well and vital signs are normal. Her BMI is 25. Her skin appears unremarkable, as is the rest of her examination. What are the most likely diagnoses? Write 6 specific differential diagnoses. All right, so I hate these questions where everything looks good, but the patient's coming in complaining of a chronic cause. For these kinds of things, it's often handy to have kind of a backup mnemonic or a way to think through all the different causes for a presentation. And for something like this, a generalised itch, I often just fall back to, well, what's anything that can make you itchy? And really, you can often build your answers around that. And so certainly the things that can lead to itch, and in an otherwise seemingly well 68-year-old, the first thing I would always think of is that renal failure. If you've ever worked on a dialysis unit or a renal unit, you'll know that itch or pruritus is an incredibly common presentation. And in particular, they've gone out of their way to specify this is a chronic itch there, 3-month history. It's a long time to be itchy for, and so it's more likely going to be one of those chronic conditions. And pointing away from things like allergy or atopy kind of as an exposure. Tied in with that then, one of the things listed is jaundice and liver disease. I think I'd be more inclined to specify liver disease or hyperbilirubinemia, but they have specified that her skin appears unremarkable. And in my opinion, I would be hesitant to put jaundice if they've kind of specified against that. But it has been seen to be an accepted answer previously, so I'd probably specify liver disease. Diabetes, again, tying into polyneuropathy, things like that, can present with chronic itch of otherwise uncertain cause. And next, of course, is thyroid disease, because let's be honest, thyroid disease can present with just about anything. Tied in with that, and calcium regulation, hyperparathyroidism can lead to chronic itch. Iron deficiency anemia, this is another one of those weird and wonderful things. I've seen a patient end up with complete paralysis of an arm due to profound iron deficiency. Malignancy, solid tumour malignancy can do that. And so can, and interesting to note, they were happy to accept solid tumour and any appropriate example of solid tumour for a point, and hematological malignancy as a separate response as well. Polycythemia, as chronic itch is a big component to presentations there. Neurological conditions as a kind of catch-all, and they would accept things like Parkinson's disease, as long as you, or MS, as long as you're giving some kind of sensible answer in that domain. Psychogenic, if everything else seems to be perfectly fine and everything else is within normal parameters, have to consider potential psychogenic causes. And of course then tying into some of our infectious causes, things like HIV, in particular HIV seroconversion, or hepatitis C, which also ties a little bit into liver disease as well. So I'd be avoiding overcoding, and also I'd be trying to diversify my answers, and I'd be having those as probably two separate things, but I wouldn't be using both of those answers in those 6 responses unless I was really caught out. Moving on then, we have another question lined up. We will put 2 minutes on the clock. Well, that's a little bit embarrassing. I forgot to put in how many you're supposed to be choosing. Very sorry, everyone. So for this one, we'd be choosing 5 and highlighting that the key thing there is what initial investigations are appropriate. So From here, there's, and for these types of questions, there's usually more than 5 correct responses, so don't feel like you're getting caught out if you're looking at things and saying, oh, but that's also correct, that's also correct. Just specify 5 that you know for a fact are going to be right. And for these things, trying to tease out the most important things here, or what's going to be best bang for buck for your initial investigations, is where the big points are at. So, of course, for this kind of presentation, you're going to have your liver function tests, your full blood count, your calcium levels, parathyroid, iron studies as we've spoken about, your UNEs tying into that renal feature, and that'll be my first response there, certainly worth 2 marks, and thyroid function tests. Now, and of course fasting glucose if we're covering diabetes as well. Would you be ordering some of these other tests down the line? Potentially. And this is where, again, highlighting where after the initial investigations, that first little trip to try and see which domain we should be looking into further to try and manage this condition. And so really it's casting that bit of a wide net, considering your differentials and then trying to work out, well, what's going to help narrow down that list and point me in the right direction. Hopefully everyone's happy with that. And of course, coming in almost at the end, guys, hang in there. 2 minutes on the clock. Her results all return normal, and her rash quickly vanishes, I should say itch rather, without further intervention. She returns a few months later. As you note, she does not have an advanced care directive. What barriers might prevent a patient from creating an advanced care directive? Please list 3 specific barriers. All right, hopefully you guys all did well there. Let's have a look at some of the answers. Now, again, let's cross that one out, and that was itch. In this case, we're trying to diversify our responses to try and maximize our marking. And so for this situation, what areas could there be potential barriers? And any sensible response with any of these 3 domains would be given the point there. So GP barriers, so what comes from us sitting in the chairs? Well, things like the perception patients are unwilling to participate or discuss death and dying, removing the fear of removing hope or damaging relationship, GP fear of challenging patient preferences or potential emotional impact on the patient, GP time constraints, GP lack of training or comfort in performing these things, and of course, the age-old thing, lack of remuneration for the time it takes, which admittedly to do these properly does take a long time, remuneration to actually perform these. Then the other side of the chair, patient barriers. So patients might not be aware they exist at all. They might be reluctant to communicate end-of-life issues. They might even see them as irrelevant to them. or believe that their wishes are already known to friends or family, or there could even be language barriers that's stopping that communication there. Now, external to those two people in those two seats, there can be health system barriers as well. And this can be with the clinic level all the way through to tertiary hospital level. Now, anyone that's filled out these forms knows already there is significant fragmentation between the states around what is contained within these directives, how legally applicable they are, and while there has been a lot of work in recent years to try and consolidate all that down, there's still a lot of work that needs to be done. There can be changes in preferences, so what people have specified in their directives at one point may be different to how things are now, and it can be cumbersome and difficult to actually track down who has copies of what and update them. Things could be poorly documented or using incomplete or inappropriate terminology as well. The catch-all term of not for life support, what does that mean? You need to be very specific and clear in terms of what you do and do not want. That ties into as well lack of clarity, as well as a poor ability to store or access advanced care directives. So is there an appropriate system in place so that these can be recorded and, if need be, retrieved for review? Excellent. Well done, everyone. Thanks for tuning in for quite so long. I know this has been a little bit longer than last week. I'm going to try and work these to last for around that 50 to 60 minute mark moving forward as well. Again, I'll be trying to run these every single Wednesday night up to the exam, including a follow-up little party and celebration for everyone after the exam as well. Now, I want to point out as well that similar to the first question, the last aspect of that last question kind of took a bit of a tangent there, and I'd be surprised if they did that in the actual exam. I am just trying to diversify the kinds of questions I'm asking to give you best bang for buck, to help you try and work out what areas do you need to be providing some extra time and study into. So, again, I hope you guys are finding these all helpful. I hope that these are helping you identify spots that you want to improve on. If you have any feedback, throw it down the bottom. Otherwise, I'm looking forward to seeing you all next week for another study session. So be well, be safe, and I'll see you guys all next week. Until then, see ya.